Hi, this is Dr. John Ellis. I'm adjunct professor in the Department of Anesthesiology and Critical Care at the University of Pennsylvania. And I've been reading some of the recent literature on OSA and perioperative management and thought I'd share some of that with you and some of my thoughts about it. This is of personal interest. You can see me here on the left about 6 years ago. I had sleep apnea, had a CPAP device, and as you know, many people with CPAP, even though prescribed, don't use it, and I was one of those people for whom it was just very, very difficult to tolerate it. So just because folks have a CPAP machine doesn't mean that they're actually getting good use of it, which is generally defined as more than 5.5 hours a night of use, and being able to get into deep enough sleep to get into REM sleep. And I'm proud of the fact that I was able to lose weight and, at least as best I can tell, no longer have sleep apnea, or at least to the same extent as I did before. So what's new in 2013? I think 10 years ago people were very excited, interested in securing airways. I think with video laryngoscopy and supraglottic devices, that has become a more straightforward thing, and I think people debate that less. I think what is new is, about 5 years ago we had the scoring systems such as Stop Bang, and we'll talk about Stop Bang some, that are used to try to predict the risk that a patient might have OSA, because most patients who have OSA don't come with a diagnosis. Another thing is that we've increasingly become aware of the particular difficulties with what I'd call the worst of the worst patients with OSA, those that have obesity hypoventilation syndrome, or those that we used to call Pickwickian. And it's been pointed out that the use of elevated bicarbonate levels on serum testing may identify patients who have the obesity hypoventilation syndrome, and also bicarb added to Stop Bang may make that a better test. What else we're going to talk about? There's some recent evidence that neuraxial anesthesia may improve outcomes in sleep apneic patients, at least those undergoing total joint replacement, and we'll touch briefly on some new guidelines that SAMBA published at the end of 2012. Well, as we all know, folks are getting bigger. You've probably seen this data from the CDC. You see back in 1991, the most obese states, dark blue, had 15 to 19% of their populations being obese. By 2010, there were no blue states. We're not talking about politics now, and you can see where the patients, or the people, have the highest prevalence of obesity, greater than 30% in a lot of these states right here predominantly. And so folks are getting bigger, and surgical patients on average are more obese than the general population. So folks keep getting bigger, and we're asked to take care of these patients. This is a very nice, very recent, just this week, editorial by Dr. Memsudis. I hope I'm pronouncing his name correctly, from the Hospital of Special Surgery in New York. And he's done a lot of important work in this area. Yes, it's storming here. He's done a lot of work in this area, and this is an editorial in the New England Journal talking about the perioperative sleep apnea epidemic. And one of the things he points out is that because of new, simple perioperative screening tools, such as Stop Bang, for assessing the risk of OSA, many patients now first receive a suggested diagnosis of OSA when they present for surgery. And this can be problematic because physicians, hospitals, clinicians in general treating patients with suspected OSA may then feel compelled to employ expensive but unproven interventions in an attempt to reduce the risk of adverse events. And that may be special surveillance units, ICU admission, step-down units, keeping people in the hospital rather than sending them home after outpatient surgery. So we really need more data to speak to how we might take care of these patients. One of my friends told me a story of, in his hospital, and this was probably 6-7 years ago, they had a multidisciplinary OSA guideline that they decided to put into place, and after a week or two the head of nursing called him up and said, "We don't have the resources to take care of these patients in the numbers that they're coming to us." And this was in the Pacific Northwest, where people tend to be thinner on average. You know, I've given lectures to clinicians in Mississippi, and they just say, you know, this is all of our patients just about. This is something that we have to live with. So we have to figure out how to take care of these patients in a cost-effective way. And then they say that this really presents a problem in the perioperative setting to treating physicians or anesthetists who must decide, do I cancel the surgery? And you cancel the surgery and send the patient to get a sleep study, maybe to get CPAP. In my own case, I got CPAP and couldn't really wear it anyway. So do you delay for all of that, or do you proceed? And if you proceed, how do you care for that patient? And do you do so in a way that adds expense? And so this is a typical rock and a hard place that we can find ourselves put in. But back to stop bang, I think, you know, for all of the limitations of it, I think Francis Chung in Toronto has done our specialty proud by developing this, not just dreaming this up, but showing that it has validity as a predictor. In other words, you ask these questions and you can do a good job of predicting who's going to have sleep apnea on a sleep study. And this has actually become adopted widely in medicine beyond just anesthesia. What are the advantages of it? We'll go through all the questions in a minute. Well, most sleep apneics still today are undiagnosed, and this is something that's very easy to do in clinic. One of the questions is it too sensitive? You know, some clinicians will say, all my patients have a stop bang of greater than 3. You know, I need something to help me discriminate more. And others would say that in being simple, all of the risk factors count equally. And this could be a problem because one might say that a history of obstruction during sleep should count more than being age greater than 50. Those are two of the questions in the stop bang. Yet in stop bang they have equal weight. So if you want to see the questions in stop bang, you can go to Francis's website. It's stop bang, www.stopbang.ca, and the questions are, and you can go online and do this. Ask the patient, do you snore? Are you tired during the day? Because if you have sleep apnea, don't sleep well, tired during the day. Has anyone observed you? This is the O. Has anyone observed you stop breathing during your sleep? Well, you can think about obstruction. P, do you have high blood pressure? Patients who have sleep apnea very often have high blood pressure, and vice versa. Patients with severe hypertension often have sleep apnea. Is the body mass index greater than 35? So that would be a definition of morbid obesity. And I certainly was above that at my highest. Is the patient older than age 50? We know this increases with age. Is the neck circumference large, and that's greater than 16 inches at the Adam's apple, 40 centimeters around? Quite frankly, I think that might be normalized, but it's not. So, you know, I'm 6'2". Maybe I should be allowed a little more. Of course, I'd say that. And male gender. And so each of these count for a point, and the more of these you have, the more likely you are to have sleep apnea. So that's stop bang. And as Memsudas points out, now this is used by many clinicians in many institutions, and now you're left with the patient say, oh, your stop bang score is 4 or 5. You might have sleep apnea. What are we going to do? You can't send all your patients for sleep study or to the ICU. So we've got to get better. One approach, and this is just sort of an aside here, is that maybe you really focus on the things that are most important. And this is a series by some orthopedists in, you know, over 1,000 total joint patients undergoing, some of them multiple total joint arthroplasties. And they identified roughly 9% of the patients having OSA by asking 3 questions. Do you have periods when you stop breathing while sleeping? And of course, as we all know, since men have this more than women, when we ask Mr. Jones, we look at Mrs. Jones for the answer. Then we ask, do you have OSA or have you been diagnosed with OSA? But remember, most of these patients are undiagnosed, and that's relevant to question 3. Do you have a CPAP or a BiPAP machine at night when you sleep? So this series says that roughly 9% of the patients had sleep apnea by one of these 3 questions, but this is probably underdiagnosing the prevalence of sleep apnea. Francis Chung is to be commended. She and others recently published this review last year in anesthesiology that looked at the obesity hypoventilation syndrome. These are the patients, the Pickwickian patients, who are chronically hypoxic, perhaps hypercarbic, and these are patients that are particularly problematic and don't do well. The diagnosis is made if patients are obese, they have a daytime awake PaCO2 greater than 45 and hypoxemia with PaO2 less than 70 and have sleep disordered breathing. And this occurs in about roughly 10%, you see the number here, 11% of patients with known OSA and 8% of bariatric surgical patients. So these are the patients who are particularly problematic. And one of the things we'll come to in a little bit is that this elevated carbon dioxide during the day may result then in a respiratory alkalosis with chronic retention of CO2 producing elevated bicarbonate levels. And this may be a way of both improving the discrimination of stop-bang and also diagnosing patients who have the obesity hypoventilation syndrome. I refer you to this review. It goes through the variety of pathophysiologic effects on different organ systems. You're aware certainly of all of these in your everyday practice, and they tend to be even more exaggerated in the patients with OHS who may have cor pulmonale, congestive heart failure, obviously difficult airway, etc. And here you can see in this flow diagram here, you see mechanisms by which both obesity and OSA can cause an increase in serum bicarbonate and elevated chronic hypercapnia. They actually have a nice little algorithm, suggested algorithm. I think this is probably more expert opinion, and you can see how this says, you know, use the stop-bang, look at the SATs, look at the bicarb, and if you think that they're at high risk for obesity hypoventilation syndrome, 3 or more on the stop-bang, the SATs less than 90, and the elevated bicarb, if they're going to have major elective surgery, these are the patients in whom you might think about sending to the for a sleep study. On the other hand, if their stop-bang score is lower, if their SAT is normal, if their bicarb is normal, they might get routine management. Now the question of course here is, what do you do with someone, I would put them in here, and we don't see that here, who has a stop-bang of 5 but their SAT's greater than 90, and maybe their bicarb is one way or another. So that's something that still needs to be resolved. But again, this issue with chronic hypercapnia, increased serum bicarbonate, may be helpful in thinking about how we make these screening tools better. And so, as always, Dr. Chung has continued to further our field here and her work in this, and showed that if you have a stop-bang of greater than 3 and a bicarb greater than 28, or greater than equal to 3, bicarb greater than or equal to 28, or you have a stop-bang greater than 6 as a cutoff, if you have that, your probability of having an AHI greater than 5 is 80%. Do I worry about an AHI of 5? I'm not sure. Greater than 15, that starts to get my attention, about 50%, and AHI greater than 30, and those are people I'd certainly be worried about. If they have all 3 of those, their chances are 30% of having that very significant amount of sleep apnea. What you can also see here is if someone has an AHI of 5 or less, only about a quarter of them have a bicarb of 28 or greater. Whereas you see here, if they have an AHI of greater than 30 on their sleep study, 44% of them are going to have an elevated bicarb. So there is sort of a dose-response relationship there. And then they show that, and you can see here with the red and the green arrows here, if we look at the worst of the worst, the people who had an AHI apnea hypopnea index of greater than 30 on a sleep study, you see that the stop-bang greater than equal to 3 plus the bicarb gives you a sensitivity that is lower, but it gives you a much better specificity. Now, specificity is negativity in health. And what this means is if you use this criteria, you're going to get fewer false positives. And so you may feel relatively assured that these patients if they don't meet that criteria, are less likely to have severe sleep apnea. So what do the guidelines say? Well, if you look back at the 2006 ASA guidelines, they stated that local anesthesia or peripheral nerve blocks rather than general anesthesia improves outcomes in patients undergoing peripheral surgery. And they say that regional analgesic techniques rather than systemic opioids reduce the likelihood of adverse outcomes in patients at increased risk from OSA. But they also point out that the literature is insufficient. They make these recommendations, but they say the literature is insufficient to evaluate the effects of various anesthetic techniques or postoperative analgesic techniques. So those are the 2006 ASA guidelines. They're now starting to get a little long in the tooth, and because these issues come up a lot in the outpatient setting, SAMBA, the Society for Ambulatory Anesthesia, came out with their own guidelines. Dr. Joshi is the lead author on this. You see Dr. Chung again with a consensus statement on perioperative or preoperative selection for patients with obstructive sleep apnea scheduled for ambulatory surgery. And they had new guidelines because there's new evidence. They particularly embrace stop-bang, and they emphasize that patients can be considered for ambulatory surgery if their postoperative pain can be managed predominantly with non-opioid analgesic techniques, even though heretofore we haven't had the best evidence for that, though it makes sense to limit opiate use in these patients. They say, on the other hand, the OSA patients who have non-optimized comorbid medical conditions may not be good candidates for ambulatory surgery. And who are those? You know, you go back among other things and you look at the patients who have obesity hypoventilation syndrome and look at their issues. Something else you might add to that is poorly controlled diabetes, etc. Those are the situations where you might think that patients are not best managed in an outpatient setting. So how are we going to anesthetize these patients? And there are a variety of choices, and they can be used by themselves or in conjunction with one another, and we'll look at some recent evidence that it talks about this. Certainly, this is an editorial that accompanied the study we're going to show next. This is an editorial from the folks at Johns Hopkins, and they point out that it's very important to have evidence that regional anesthesia and analgesia may be useful, because they point out the guidelines in 2006 from the ASA on OSA really say there's no evidence. So they really applauded, and this is again Dr. Memsudis again and his group at the Hospital for Special Surgery in New York, and they did a large database retrospective study to look at the relationship between anesthetic technique and outcome after total joint arthroplasty, hips and knees. And they're obviously a very busy center for that, but this wasn't just at the Hospital of Special Surgery. This was at, I think, several hundred hospitals that they got data from. And as you can see, if you look at the prevalence of comorbidities, you can see the vast majority of these patients are hypertensive undergoing joint arthroplasty. Half of them are obese. You know, probably a third of them have uncomplicated diabetes. So the typical population you would expect for major joint replacement. Now, first off, this is basically a study of spinal or epidural neuraxial versus general, but they did collect a little bit of information about peripheral nerve blocks. This study was on retrospective study on real patients, not clinical trial, collected between 2006 and 2010, and that's probably a time when the use of peripheral nerve blocks was increasing. But what you see here is in this series, peripheral nerve blocks were used very infrequently. Only 8% of the patients that got GA were recorded as having had a peripheral nerve block, and only about 1% in those that had either a neuraxial or combined general neuraxial. They actually did not find reduced perioperative complications in patients who had peripheral nerve blocks, although again the population was small. They did find that there was less need for mechanical ventilation or post-op admission to the ICU in the patients that had peripheral nerve blocks. So that's some promising data that hopefully people can look at more in the future. This next slide compares the three groups, and this is far too much to go through, so we're going to simplify it the next slide. But bottom line, they look at the complications of different sorts in those, and they compared the neuraxial to the general, the combined neuraxial general to the general, and the combined neuraxial general to the neuraxial. And the question is, because, you know, to get to the punchline, there were benefits of neuraxial, and the question is neuraxial good or is general bad? Because looking at the combination of them may get at that, and what you tend to find the results is that the combined neuraxial general tends to look kind of in between general and neuraxial. And again, one of the questions is, if you have a combined neuraxial general, is that a neuraxial that started out that way that failed and converted to general. So there are all these complications and things you can't really figure out in a retrospective study. But here we just put here combined neuraxial general to general, and here you see that adding neuraxial to general appears to reduce combined complications, reduces pulmonary complications. Those are the things that are significant, and seems to reduce blood transfusion as well. So those are all, possible significant benefits. They actually thought here that you should have a more stringent criteria for statistical significance, given that the data set was so large. And so you see here mechanical ventilation, ICU use, length of stay in the hospital, and the percentage of patients who had significantly increased cost of hospitalization. All those were reduced with combined neuraxial general compared to general, which to me suggests that there's something good about neuraxial anesthesia. Now there are limitations. It's a retrospective study. As they say, large size means that maybe you should look at much smaller p-values to get statistical significance. The other thing to point out is keep in mind the concept of number needed to treat. When you have, I don't know, 40,000 patients, I think, in this retrospective review, you can have something that's very statistically significant, and yet it might not be clinically significant. So I just played with the numbers, and I got a guesstimate. And this is just a guesstimate based on the numbers. This is not accurate. That if ICU admission has an odds ratio of 0.433, and that's extremely significant, with a pretty tight 95% confidence interval, my guesstimate would be that you would have to do about 30 neuraxial blocks as opposed to generals to prevent one ICU admission. And many of you would say, that's great. I do 30 blocks, I prevent one ICU admission. That's great. For folks who are fans of general anesthesia, they say, well, what about the anti-thrombosis prophylaxis, et cetera, or, there are always patients that, don't want regional anesthesia, neuraxial anesthesia, et cetera. But my sort of back-of-the-napkin calculation is if you do 30 neuraxial blocks, based on this data, you might prevent one ICU admission. The other problem with this retrospective study is that this was done only in known sleep apneics. Now remember, we said most patients with sleep apnea are undiagnosed. Now you might guess that the ones who are diagnosed have it more severe, maybe yes, maybe no. But on the other hand, once someone has a diagnosis, maybe they get treated differently, maybe they get monitored differently, maybe they get a different anesthetic technique, maybe they have more routine CPAP use. Another limitation of the study was that all they knew is whether or not the patients had sleep apnea. They had no information from their medical records about how severe it was on their sleep study. And the big question is, does it matter more in certain subgroups? Maybe it matters more in the patients who have BMIs that are morbidly obese. Maybe in the thinner patients it doesn't matter so much. I'm only speculating, but these are questions that were unanswered in that study. So just to review, I think what we've talked about is that, what's new in OSA 2013, I think airway management has become less controversial. Stop bang has been used widely. Some people have become disillusioned with it because it may be too sensitive. New studies show that bicarbonate may improve the use of stop bang as a pre-op predictor of significant sleep apnea, and may also help to diagnose the worst of the worst, that perhaps 10% of patients who have the obesity hypoventilation syndrome. We now have some evidence that neuraxial anesthesia may improve outcomes in patients with known sleep apneics, and particularly for issues that relate to outpatient ambulatory surgery, I would refer you to the SAMBA guidelines that were published last year in 2012. And so I thank you very much for spending the time to listen to this lecture. Hope you found it useful. You see my email address here, johnellis1700@gmail.com. If you have questions or comments, please feel free to contact me. Thank you so very much.